Ladies and gentlemen, dear colleagues and friends, it's a tremendous honor and privilege for me to be here and talk about current treatment options of patients with metastatic colorectal cancer. My name is Ulrich Güller. I'm affiliated with two institutions, with the medical oncology of the Kantonsspital St. Gallen, as well as with the University Clinic for Viszeral Surgery and Medicine at the University of Bern. I have no conflicts of interest. What are the objectives of the upcoming hour? The objectives are to give you a critical overview on current treatment options of patients with never resectable metastatic colorectal cancer. In the interest of brevity, I will exclude potentially resectable patients after neoadjuvant systemic treatment. Also, I will exclude systemic treatment of elderly and frail patients, so this is not a comprehensive overview. However, I will try to touch on a few very relevant topics. So I'll be talking about mutational analysis, first-line treatments, head-to-head studies, maintenance therapy, pros and cons, second and third-line treatments, new systemic treatment options, as well as local treatments such as surgery, radiofrequency ablation, and selective internal radiation treatment. So let's go in medias res. Metastatic colorectal cancer, as you all know, is a very heterogeneous disease, and hence mutational analysis are of tremendous importance. Now, this has been acknowledged in a recent paper published in the JCO by Carmen Allega and colleagues regarding the importance of RAS and BRAF mutational analysis in metastatic colorectal cancer patients. The past, ladies and gentlemen, is to look for KRAS exon 2 mutations. The current standard is to look for KRAS exon 2, 3, and 4 mutations, for NRAS exon 2, 3, and 4, and for BRAF exon 15 mutations. So what is the importance of mutational analysis? Well, first and foremost, it's prognostic. And for metastatic colon cancer, as for Clint Eastwood, there's the good, there is the bad, and there is the ugly. These are data from the TRIBE study, from an update from Lancet Oncology last year. On the axis here you see follow-up in months. On the ordinate you see overall survival. And as you can see, ladies and gentlemen, there's three very distinctive subgroups. We have the blue line. These are patients with pan-RAS, BRAF, wild type. And these are the good ones. They have a median overall survival of approximately 3 years. And then you have the green line. These are patients with an NRAS or a KRAS mutations. And these are the bad ones. They have a median overall survival of only about 24 months. And finally, you have the ugly subgroup, the patients in red here. These are BRAF mutated patients with a very poor prognosis and a median overall survival anywhere between 8 and 12 months. So mutational analysis are important regarding prognosis. However, they're also predictive and help us choosing first-line treatment. Why is that important? If we have an activating mutation in KRAS or NRAS genes, there is an activation of downstream signaling and cancer cell proliferation. And hence there's a lack of response to EGFR antibodies. And EGFR antibodies may even potentially be harmful in patients with RAS mutations, particularly with a full FOX backbone. So there's a predictive value of RAS mutations, no EGFR antibodies in patients with KRAS or NRAS mutation. One size fits all, ladies and gentlemen, is in the past, and we're going towards a patient-tailored treatment in metastatic colorectal cancer. How frequent are these mutations? There's approximately 40% of KRAS exon 2 mutations. However, there's an additional 15% of mutations in KRAS exon 3 and 4, in NRAS exon 2, 3, and 4, and in BRAF exon 15. And it's important to look for these additional mutations. So, metastatic colorectal cancer, again, it's a very heterogeneous disease, and mutational analysis are mandatory prior to first-line treatment. So what is the ideal first-line therapy in patients with metastatic colorectal cancer? Let's look at RAS and BRAF wild-type patients first. Well, there's 3 head-to-head comparisons of chemotherapy doublet plus antibody. There's the PEAK trial, which is a large phase 2 trial in patients with first-line treatment, KRAS exon 2 wild type, and they were randomized 1:1 to FOLFOX bevacizumab versus FOLFOX panitumumab. There's the FIRE3 trial, which is about twice as large as the PEAK trial. This is a phase 3 trial, first-line treatment of patients with advanced metastatic colorectal cancer. And these patients were randomized 1:1 to FOLFIRI bevacizumab versus FOLFIRI cetuximab. And finally, there's the CLGB SWOG 8405 trial, which randomizes patients to chemotherapy doublet. This was at the discretion of the treating medical oncologist, plus bevacizumab, versus chemotherapy doublet and cetuximab. Let's look at the FIRE3 data first. This was published in Lancet Oncology 2014. First author was Volker Heinemann. And here again is the study design. Again, this is first-line treatment in patients with KRAS exon 2 wild type. And these patients, almost 600, were 1:1 randomized to FOLFIRI cetuximab versus FOLFIRI bevacizumab. Primary endpoint was overall response rate. This trial was performed in Germany and in Austria. And here are the results. Overall response rate, this was the primary endpoint, was not statistically significantly different, 62% versus 58%. No difference regarding progression-free survival, 10 months in both arms. However, there was a very relevant overall survival difference in favor of the cetuximab, 25 months versus 28.7 months. It's a delta of 3.7 months. Now, if you look at the after extended RAS analysis, if you look at the pan-RAS wild-type patients, the difference in favor of cetuximab increases to 7.5 months. So conclusion of FIRE3 is no significant difference in objective response rate and PFS. However, there is a very relevant overall survival increase with FOLFIRI and cetuximab, and extended RAS analysis are of prime importance. Let's look at the PEAK trial. Again, this is a large and important phase 2 trial randomizing patients in first line to FOLFOX bevacizumab versus FOLFOX panitumumab. And here's the progression-free survival in patients with KRAS exon 2 wild type and pan-RAS wild type. There's no difference in PFS in the KRAS exon 2 wild type group. There appears to be a statistically significant difference in favor of the panitumumab arm after extended RAS analysis. And here's overall survival in the PEAK trial, and as you can see, ladies and gentlemen, there's a relevant overall survival increase in patients receiving FOLFOX and panitumumab. The difference was 9.9 months in the KRAS exon 2 wild type group. It was 12 months after extended RAS analysis. So, conclusions of the PEAK trial: no significant PFS difference in KRAS exon 2 wild type patients. There is a statistically significant PFS difference after extended RAS analysis in the pan wild type patients, and there's a very relevant overall survival increase with FOLFOX and panitumumab. Let's go to the third trial, CLGB SWOG 8405. This trial was presented by Alan Vanuk at ASCO pretty much 2 years ago. So here's the initial study design. These were patients with untreated KRAS exon 2 wild type advanced colorectal cancer, and patients were randomized initially to 1 out of 3 arms, chemotherapy doublet, and again this was at the discretion of the treating medical oncologist, plus bevacizumab, chemo doublet plus cetuximab, and there was a third arm, chemotherapy doublet plus bevacizumab and cetuximab. Arm 3 was closed after data came out that the combination of bevacizumab and cetuximab may be potentially harmful. So here's the final study design. Again, chemo doublet plus cetuximab versus chemo doublet plus bevacizumab. Over 1,100 patients were included, and the primary endpoint was overall survival. And here's the results. Overall survival, as you can see, ladies and gentlemen, chemotherapy and cetuximab at 29.9 months. Chemotherapy plus beva, 29 months. This was not statistically significantly different. And here's progression-free survival. Again, no statistically significant difference, was 10.5 months approximately in both arms. Now let's look at the subgroups of patients receiving FOLFOX as the chemotherapy backbone. This was about 3/4 of all patients, which reflects the current practice in the United States. They're favoring FOLFOX over FOLFIRI. So in the FOLFOX subgroup, there appears to be a numerical benefit of cetuximab 30 months versus 26.9 months. There was a trend towards statistical significance. Now let's look at the FOLFIRI subgroup, and this is interesting. FOLFIRI bevacizumab had a median overall survival of 33 months, whereas FOLFIRI cetuximab had a median overall survival of 28.9 months, and this was not statistically significantly different. Now let's compare this to the FIRE3 data. FOLFIRI cetuximab in the FIRE study in the KRAS exon 2 wild-type group had a median overall survival of 28.7 months. And this is very comparable with the SWOG data, FOLFIRI cetuximab 28.9 months. However, the FOLFIRI bevacizumab arm in FIRE3 had a median overall survival of 25 months, and there's a large discrepancy to the SWOG CLGB study with 33.4 months. It's unclear at this point in time why this large discrepancy exists. Objective response rate was significantly better in the doublet cetuximab arm, 66 versus 57%. So the conclusions of the CLGB SWOG trial was overall survival on chemo cetuximab is no different than on chemo bevacizumab in first-line treatment for patients with KRAS wild-type metastatic colorectal cancer. And FOLFIRI or FOLFOX with either bevacizumab or cetuximab can be considered options for first-line therapy of patients with KRAS wild-type metastatic colorectal cancer. I believe these conclusions are premature, and I'm going to tell you why. There's a lot of missing information regarding the CLGB SWOG trial. What was the location of the metastases? Liver, lung, peritoneum? Were there any discrepancies between the two arms? What was the treatment duration in first line, treatment intensity in first line, second line therapy, third line therapy, and so forth? And most importantly, only about 55% of all patients had an extended RAS analysis. So, definitive analysis are pending. I'm slightly irritated, I must say, that there's no publication of the CLGB SWOG trial 2 years after the trial was presented at ASCO 2014, and current results must be interpreted at least with some caution. So, first-line treatment in patients with pan-RAS wild-type, what should we give? There's a nice meta-analysis combining all three trials, PEAK, FIRE3, and CLGB, published in the Clinical Colorectal Cancer Journal 2015, and they found a higher objective response rate with EGFR antibodies. Hazard ratio was 1.46. This was statistically significantly different. And overall survival was also better with an EGFR antibody as a first-line treatment with a hazard ratio of 0.77 and a p-value of 0.016. So conclusion of this meta-analysis was the results of our research show superior objective response rate and overall survival with first-line anti-EGFR therapy compared with anti-VEGF therapy in both KRAS wild-type and pan-RAS wild-type patients with advanced colorectal cancer. So again, in pan-RAS, BRAF wild-type patient, start with a doublet plus EGFR antibody. So what should we do in patients with KRAS and NRAS mutation? And there's a very important trial published in the New England Journal of Medicine in 2014 by Fotios Loupakis. There was an update about a year later by Chiara Gremolini and published in the Lancet Oncology 2015. What was the TRIBE trial all about? This is a randomized controlled trial in first line. Over 500 patients were enrolled with metastatic colorectal cancer. Arm 1, this was the experimental arm, was FOLFOXIRI-BEVA versus Arm 2 is FOLFIRI bevacizumab. And here's the results of progression-free survival. And as you can see, ladies and gentlemen, there's an advantage of the experimental arm using FOLFOXIRI-BEVA, 12.3 versus 9.7 months. This was statistically significant. But what really matters is overall survival, and also for the overall survival there was a significant benefit in favor of the experimental arm of FOLFOXIRI-BEVA, 29.8 versus 24.8 months. This is a difference of 4 months. This is not just statistically significant, this is clinically relevant. So let's look at RAS mutations in the TRIBE trial. This is progression-free survival, and as you can see, ladies and gentlemen, both non-mutated and mutated patients appear to benefit from the experimental treatment. And again, the experimental treatment was triplet FOLFOXIRI plus bevacizumab. This was not statistically significant. The 95% confidence intervals crossed the one line. However, the study wasn't powered to show a significance in the subgroup. Let's look at overall survival in patients with RAS mutations. You see FOLFIRI plus bevacizumab had an overall survival of 23.9 months versus 27.3 months in FOLFOXIRI bevacizumab. This was a difference of 3.4 months. And for PFS, similar, a difference of 2.5 months in favor of the experimental arm, FOLFOXIRI bevacizumab. So first-line treatment in patients with KRAS and NRAS mutations, a triplet plus bevacizumab appears to be better than a doublet plus bevacizumab. What should we do in patients with BRAF mutations? And again, BRAF mutated patients, these are difficult to treat. They have the worst prognosis. You usually only have one kick at the can. You got to shoot with all you've got. So these are the data from the TRIBE trial, PFS data, and as you can see, there's a small subgroup of patients with BRAF mutations. However, in the small subgroup, they appear to benefit from the triplet plus bevacizumab compared to FOLFIRI and bevacizumab. Now here's overall survival, and overall survival in the group receiving FOLFOXIRI bevacizumab was 19 months, which is unheard of for BRAF mutated metastatic colorectal cancer patients. Most previous studies reported a median overall survival for BRAF mutated metastatic colorectal cancer anywhere between 8 and 10 months. The median overall survival for FOLFIRI bevacizumab was 10.7 months. Hazard ratio was low at 0.54. So here's a summary. First-line treatment. These are fit patients. Again, I'm not talking about elderly or frail patients. If you have pan-RAS, BRAF, wild-type patients, use an EGFR antibody plus a doublet in first line. For patients with KRAS or NRAS mutations, use a doublet plus beva, or based on the TRIBE trial, a triplet plus beva if the patient is fit. BRAF mutations, again, use a triplet plus beva. You've got to shoot with all you've got, or enroll patients in a clinical trial. So let's talk about second-line treatment. And if we talk about second-line treatment, we ought to talk about maintenance versus stop and go. There's some very renowned medical oncologists in the world who claim that maintenance treatment is the standard of care for all patients with metastatic colorectal cancer. I'm going to be frank with you, ladies and gentlemen. I'm going to get the cat out of the bag. I think this is absolutely, positively wrong. I'm going to tell you why. Let's look at the most recently published data, KRO3, AIO 0207, SAKK, and then there's a nice meta-analysis and systematic review. Let's start with the KRO3 data. This was published in Lancet in 2015 and was presented for the first time at ASCO 3 years ago, ASCO 2013 by Miriam Kopman. What did they do in KRO3? Patients were enrolled and were induced with Capox-Beva for 6 cycles, so 18 weeks. And patients who were at least stable or responded were randomized 1-to-1 to observation versus capecitabine and bevacizumab until first progression. And then they were re-induced with the same regime, Capox-Beva, until second progression. And PFS2 was the primary endpoint of this trial. So here's the results. PFS1 is significantly better in the maintenance arm compared to no maintenance. This is not surprising. By giving continuous anti-neoplastic treatment, we're pushing the progression back. PFS2 was better as well in the maintenance arm. Again, not surprising. However, really matters to patients' overall survival, and there was no statistically significant difference. Now, how is quality of life in the KRO3 trial? In the maintenance arm, there were significantly more grade 3 hand-foot syndrome, 23 versus 0%. This was statistically significant. and significantly more grade 3 and 4 side effects, 60 versus 34%. And 10% of all patients stopped maintenance due to side effects. So quality of life overall was significantly worse in the maintenance arm. This was based on the ERTC quality of life questionnaire. Conclusion of KR3, PFS is better. Again, not surprising, we're pushing the progression back by giving continuous anti-neoplastic treatment. No overall survival difference. There's significantly more side effects and quality of life is worse. There's a few critiques I'd like to make about KR3. First and foremost, at progression, they were re-induced with the same regime of K-Box-Beva. I never understood that concept. We have a variety of active drugs in the armamentarium of metastatic colorectal cancer, yet we're using the same 3 drugs over and over and over again. And oxaliplatin, we all know there's cumulative neurotoxicity, which is painful for the patient. And only 13% of all patients received an EGFR antibody, which is very low and probably which is the reason that overall survival was modest in both arms. And results are simply not generalizable to patient cohort receiving EGFR antibodies to a higher extent. I'm sure there's a subgroup of patients with greatest benefit from maintenance. There's a subgroup of patients who does benefit from maintenance. Patients with peritoneal metastases, they become rapidly symptomatic. Patients with diffuse hepatic metastases, with high LDH, with rapid progression, high tumor dynamic, BRAF mutated patients. The objective, however, of further studies must be to better define the subgroup. So let's look at the AIO-0207 trial. This was published in Lancet Oncology 2015 by Susanna Hegewisch-Becker. Derek Arnold is the senior author of this study. This is a trial where metastatic colorectal cancer patients were induced 24 weeks with 5-FU Beva plus oxaliplatin. And then patients who were at least stable were randomized to 1 out of 3 arms. Arm 1 was full 5-FU Beva. Arm 2 was Beva alone, and Arm 3 was no treatment until first progression. And then there was a reinduction of 5-FU plus or minus Beva plus or minus oxaliplatin until second progression. This was called time to failure of strategy and was the first endpoint of this trial. So here's PFS, and again, PFS is better in the 5-FU bevacizumab arm. Not surprising. Progression is pushed back by giving continuous anti-neoplastic treatment. No difference in the first endpoint time to failure of strategy, and most importantly, no overall survival difference. The curves are basically the same. So conclusions of the AIO-0207 trial, PFS is better, but time to failure of strategy, no difference, and most importantly, no overall survival benefit. Let's look at the SAKK 4106 trial. This was published in Annals Oncology last year and was first authored by Dieter Köberle. This was an open-label phase 3 randomized controlled trial. About 260 patients were enrolled who were at least stable after 4 to 6 months of first-line chemotherapy plus bevacizumab. And patients were 1-to-1 randomized to bevacizumab versus observation. And this was a non-inferiority design. So here's PFS. PFS a bit better in the Beva arm compared to the no maintenance arm. No overall survival difference, 25 versus 23.8 months. Now, this is interesting. They did a cost analysis and found that the median cost in the observation arm was $8,000 compared to $37,596 in the maintenance arm. This difference was roughly $30,000, and this difference is now highly statistically significant. So conclusion of the SAKK trial was based on no impact on overall survival and increased cost, bevacizumab is of no meaningful therapeutic value. So conclusion of SAKK trial, no overall survival difference. Be aware there's a financial toxicity. And bevacizumab maintenance, even the maintenance aficionados would agree, is out. Let's look at a nice systematic review and meta-analysis by the Princess Margaret Group in Toronto, surrounded by Monika Krzyzanowska. They looked at all different maintenance studies, and here's the overall result. And as you can see, ladies and gentlemen, it crosses the one line, so there's no significant overall survival difference. So conclusion of this meta-analysis: no overall survival benefit of maintenance treatment, and quality of life is equal to or worse with maintenance. So maintenance versus stop and go, no OS difference. PFS is better, again, not surprising. But the question is really, is PFS a valuable surrogate marker? And there's a very nice publication by Christopher Booth and Elizabeth Eisenhower in the JCO 2012, Progression-Free Survival, Meaningful or Simply Measurable. And the conclusion of this very nice article is, let us not assign meaning to something that is merely measurable, progression-free survival, while failing to measure or failing to make decisions on those things, quality of life and overall survival, that are truly important. Take-home messages: no significant overall survival benefit with maintenance. PFS is better, but PFS is a poor surrogate marker. Relevant for the patients, ladies and gentlemen, are two things: quality of life and overall survival. There's more side effects in the maintenance arm. There's a financial toxicity, and many patients do not benefit from maintenance. Metastatic colorectal cancer is a heterogeneous disease, and again, it really doesn't make sense to treat all patients the same. There's a subgroup, no doubt, benefiting from maintenance treatment. The objective of further studies, however, is to better define this subgroup. So again, maintenance for everybody is simply wrong. So let's look at second-line treatments and anti-angiogenic agents. There's three randomized trials: the TML trial, bevacizumab beyond progression in second line. There's the Volure trial, FOLFIRI plus minus aflibercept, the VEGF trap. And there's the RAISE trial, FOLFIRI plus minus ramucirumab. And here's the results. All three trials showed a significant overall survival advantage of the anti-angiogenic agent. If you look at the data a bit more closely, the overall survival increase is very similar. It's approximately 1.5 months in favor of the anti-angiogenic agent. The hazard ratio is approximately 0.01. So there is a statistically significant overall survival increase. The absolute difference, ladies and gentlemen, is rather modest, approximately 1.5 months. Let's look at third-line treatments. There is the CORRECT trial using regorafenib in third line. This was a randomized, placebo-controlled, multi-center trial in heavily pre-treated metastatic colorectal cancer patients. And these patients were 2-to-1 randomized to regorafenib, 160 milligrams, 3 weeks on, 1 week off, versus best supportive care. And here's overall survival. This was statistically significantly better in the regorafenib group. And here's progression-free survival with a low hazard ratio of 0.49, also in favor of the regorafenib. Now, the CORRECT trial has been confirmed by a second randomized placebo-controlled trial, which was performed in an Asian population. Again, these were heavily pre-treated patients who were 2-to-1 randomized to rego versus best supportive care. This was published in Lancet Oncology 2015. And again, in the CONCUR trial, there was a statistically significant PFS and overall survival benefit in favor of regorafenib. So we now have 2 phase 3 studies showing that regorafenib is superior to best supportive care in heavily pretreated metastatic colorectal cancer. Let's look at another trial, the RECOURSE trial, which was published in New England Journal of Medicine last year. Now, this was a randomized placebo-controlled phase 3 trial, a multi-center trial, multinational trial. It was performed in Asia, in Europe, and North America. 800 patients were enrolled with advanced colorectal cancer and after progression after standard therapies. And these patients were 2-to-1 randomized to TAS-102, an oral drug versus best supportive care. Primary endpoint was overall survival. And here's the primary endpoint, overall survival. There appears to be a significant benefit of TAS-102 compared to best supportive care. And PFS was also statistically significantly better in the TAS-102 arm. So with regorafenib and TAS-102, we have 2 active drugs for patients with heavily pre-treated metastatic colorectal cancer. So what was the situation in 2003? We basically had only 2 chemotherapy drugs, 5-FU and irinotecan, What's the situation now? We have a variety of drugs, more chemotherapy, VEGF trap antibodies, and tyrosine kinase inhibitors, all in the armamentarium against metastatic colorectal cancer. And hence, median overall survival has dramatically risen over the past 3 decades. This was median overall survival in 1987. 30 years ago was about 5 months, and nowadays we're approaching the 3-year mark, and this is never resectable metastatic colorectal cancer. So what are future treatment options in patients with metastatic colorectal cancer? Checkpoint inhibitors, particularly in mismatch repair deficient patients, and anti-HER2 drugs in HER2-positive metastatic colorectal cancer patients. And there was an interesting presentation at ASCO 2015 by Dong Li from the Hopkins about PD-1 blockade in tumors with mismatch repair deficiency. And this was published the same day in New England Journal of Medicine. Why would we even look at mismatch repair deficiency? Well, we do know that the number of mutations per tumor for sporadic adult colorectal cancer in mismatch repair proficient colon cancer patients is much, much lower. It's less than 100 compared to over 1,000 in patients with mismatch repair deficient colorectal cancers. And due to these mutations, there's new antigens. The neoantigen burden is higher, and this represents a target for immunotherapy. So what did Dong Li and colleagues do in this very small but very elegant study? They had 3 cohorts. Cohort A was patients with colorectal cancer deficient in mismatch repair. Cohort B was patients with colorectal cancer proficient in mismatch repair. And then there was a third cohort of patients with non-colorectal cancers with mismatch repair deficiency. Patients were treated with pembrolizumab, 10 milligrams per kilogram body weight every couple of weeks. And the primary endpoint was immune-related 20-week PFS rate and response rate. And here's the results. This is percentage of tumor marker change. On the axis here is time in days, and as you can see, there's the green group, which is basically benefiting from these checkpoint inhibitors, and these are mismatch repair deficient colorectal cancer patients. The red group appears to have no benefit of pembrolizumab, and these are mismatch repair proficient colorectal cancer patients. And if you look at objective response rate, there was 62% in patients with mismatch repair deficient colorectal cancer patients, 0% in patients with mismatch repair proficient colorectal cancer, and again 60% in mismatch repair deficient non-colorectal cancer. So mismatch repair deficiency appears to be a potential important predictor for response to checkpoint inhibitors. There's currently ongoing phase 3 studies in first line, and there also will be an update on the data of using checkpoint inhibitors in metastatic colorectal cancer patients at ASCO 2016 in about 1 week's time by Dong Li regarding pembrolizumab. Checkmate 142, this is nivolumab plus minus ipilimumab, and there's a nice study regarding cobimetinib and atezolizumab. So let's look at another very small but very elegant trial. This is the Heracles trial. This was a proof of concept phase 2 trial performed by 4 Italian academic centers in patients with heavily pretreated metastatic colorectal cancer, and they were HER2 positive tumors. HER2 positivity was defined using immunohistochemistry and FISH. And patients, HER2 positive patients, were treated with trastuzumab 4 milligrams per kilogram body weight loading dose, and then 2 milligrams per kilogram body weight weekly, plus lapatinib 1,000 milligrams daily as an oral treatment. 914 patients were screened, and 27 patients, this is 3%, it's a very small subset with HER2 positive tumors, were enrolled. Surprisingly, in these heavily pretreated patients, there was an objective response rate of 8 out of 27 patients. And as you can see, the patients that appear to benefit most on this waterfall plot are patients who are strongly HER2 positive with an immunohistochemistry score of 3+. You can also see this is progression-free survival, and patients with a high HER2 gene copy number appear to have a much better progression-free survival compared to patients with a lower HER2 gene copy number. So the conclusion of this interesting trial, which was published in Lancet Oncology 2016, was the combination of trastuzumab and lapatinib is active and well tolerated in treatment refractory patients with HER2-positive metastatic colorectal cancer patients. And HER2 gene copy number and HER2 expression appear to be associated with response to treatment. So what other arrows do we have in the armamentarium against metastatic colorectal cancer? We have surgery, we have SIRT, selective internal radiation therapy, and we have RFA. Let's look at surgery first. There's a frequent question, should we resect the primary tumor in patients with colorectal cancer and non-resectable distant metastases? There's a very nice study performed by our own group and published in Annals of Surgery last year. We used the SIR database, included over 37,000 patients from 1998 to 2009 with metastatic colorectal cancer and no resection of metastases. And we compared overall survival and cancer-specific survival in patients with and without primary tumor resection. And we did that using univariate analysis, multivariate analysis, and propensity score matching. And what did we find? These are the years. This is median overall survival. We found systematically superior median overall survival in patients who had their primary tumor removed. And this was also true in patients, this was also true for median cancer-specific survival. So the conclusion of our study was primary tumor resection appears to be associated with significantly better overall and cancer-specific survival. And this was true in univariate, in multivariate analysis, and even after propensity score matching. However, there may be selection bias. There's no doubt in my mind that patients undergoing primary tumor resection, they're on average younger, they're less comorbid, they have a better performance status, and a lesser tumor load. And hence, we do need prospective randomized trials. There's two RCTs ongoing, synchronous trial in Germany and the KRO4 trial in Holland. These are patients with metastatic colorectal cancer with non-resectable metastasis and an asymptomatic primary tumor, which are 1-to-1 randomized to resection of primary cancer followed by systemic treatment versus systemic treatment only. Let's look at the SIRFLOX study. This was presented by Peter Gibbs from Melbourne at ASCO 2015 and was published a couple of months ago in the JCO. What is selective internal radiation therapy? The interventional radiologist punctures the femoral artery and goes up to the hepatic artery, and there he delivers radioactive particles, yttrium-90, in a one-time fashion. This was the study design. These were patients with liver predominant or liver only unresectable metastatic colorectal cancer. They were randomized 1-to-1 to systemic treatment FOLFOX plus beva versus systemic treatment FOLFOX beva plus a one-time selective internal radiation treatment. Now, the primary endpoint was progression-free survival and was not statistically different. As you can see, the curves, they do overlap. However, this was probably due to a large fraction of patients with extrahepatic metastases. Now, if you look at the progression-free survival in liver, there appeared to be a statistically significant difference and with a hazard ratio which is low of 0.69 and an almost 8 months difference in favor of SIRT regarding progression in the liver. So SIRFLOX trial primary endpoint PFS was not met. However, again, they had a large fraction of patients with extrahepatic disease, which you can't impact using SIRT. Liver PFS was significantly improved, and we're all awaiting eagerly overall survival data, hopefully in 2017. Now let's look at the CLOCK trial, which was presented by Theo Ruers last year at ASCO. This is a small but important randomized controlled trial randomizing patients with up to 9 liver metastases to radiofrequency ablation plus systemic treatment plus resection if that was an option versus systemic treatment plus resection if that was an option. And here's progression-free survival. As you can see, ladies and gentlemen, progression-free survival was significantly better in the combination arm of systemic treatment plus RFA. And even overall survival, there was a 5 months difference in favor of the combination RFA plus systemic treatment. So the conclusion of the clock trial was overall survival and PFS benefit in patients undergoing RFA plus systemic treatment versus systemic treatment alone. I'm concluding this talk. Metastatic colorectal cancer is a very heterogeneous disease, and hence mutational analysis are of tremendous importance. They have a prognostic impact. We do have the good pan-RAS, BRAF wild-type patients. We have the bad patients with a NRAS or KRAS mutation. And we have the ugly, the worst prognosis is patients with BRAF mutation. But also mutational analysis are predictive and help us choosing the first-line treatment. If we do have an activating mutation in KRAS or NRAS gene, we have an activation of downstream signaling and cancer cell proliferation, and there's a lack of response to EGFR antibodies, and there may even be a potential harm, particularly if you have FOLFOX as a chemo backbone. First-line treatment in pan-RAS, BRAF wild-type patients give an EGFR antibody plus duplet. In patients with KRAS and NRAS mutation, give duplet plus beva, or based on the TRIBE trial, triplet, FOLFOXIRI plus beva. And patients with BRAF mutations, again, you get usually one kick at the can, you got to shoot with all you've got, give a triplet plus beva, or enroll in a clinical trial. Maintenance versus stop and go, no overall survival benefit. PFS is better, but then again, PFS is a poor surrogate marker. There's two things, ladies and gentlemen, that matter to patients. Number one is overall survival. Number two is quality of life. Metastatic colorectal cancer is a heterogeneous disease. It doesn't make sense to treat all patients the same way. There's a subgroup of patients benefiting from maintenance treatment, and the objective of further studies is to better define this subgroup. Second-line anti-angiogenic agents, GML study, Velour study, and RAISE study, there is a statistically significant overall survival benefit. However, the absolute clinical difference is rather modest. Third-line treatment, we have two active drugs now, regorafenib and TAS-102, for patients with heavily pretreated metastatic colorectal cancer. Future treatment options, hopefully checkpoint inhibitors in mismatch repair deficient patients, and anti-HER2 drugs in HER2-positive metastatic colorectal cancer patients. Local treatments, surgery, radiofrequency ablation, and selective internal radiation therapy. Again, overall survival data are pending. Situation in 2003, we had two chemotherapy drugs. 13 years later, we're way better off with a variety of different drugs: chemotherapy, VEGF trap, antibody, and tyrosine kinase inhibitor. And hence, median overall survival has dramatically risen in patients with never resectable metastatic colorectal cancer over the past 3 decades. What is the future? We need to identify further predictive biomarkers. We need to be more careful about cancer cell heterogeneity. We need to use biobanks, basic research, translational research, big data, new targets, and new drugs. One size fits all, ladies and gentlemen, is in the past, and we're going towards a patient-tailored treatment. Only if we treat the patient individually will we be able to maximize efficacy, minimize toxicity, and provide efficient healthcare delivery. Thank you very much for your kind attention.